for the past year, we've had Dr. Elorriaga present 6 different parts to his Neurofunctional Electroacupuncture series. And today we thought that we'd concentrate a little bit on a bit of review of those 6 parts. Any questions anyone has, now would be the time to ask it. Our next part to this series is actually going to be a live case presentation where he'll go through all of his style. That live case presentation won't be recorded. So this will be the last recording of that series, which will still be available to watch, but for a limited time. So today, it's a little bit of a different feel. We'll let Dr. Elorriaga speak, and then we'll hop into any Q&A. So if you guys have come with questions, we'd love to hear them. Please type them into the Q&A box. If you don't see it along your bottom navigation bar, if you click the Marching Ants More button, it might be in there. So if you type your answers or questions into the Q&A, I'll be sure that we get to them and I will ask. So right now, we will let Dr. Elorriaga take over.
Thank you, Sulin, and thank you everyone for taking the time to attend this session. It's the idea was to help you implement some of what we've done, and also to give you the framework in which is possible to do such an implementation. The first observation is that information is not knowledge. You've had a lot of information in these presentations, and information is data. Data can be easily acquired nowadays. You have ChatGPT, the paid version. It will give you factual data in seconds relative to any topic. However, that would not lead to knowledge, even though it would be a first step. Knowledge is organized information to begin with, but it needs to be applied to something in order to become a skill or part of a skill. And in this clinical work of us, of ours, is important to have a method by which we can convert knowledge into skill as a prerequisite to then being able to complete the process, which would be the transformation of skills into expertise, problem-solving expertise. For instance, an athlete, a tennis player, is going to require to learn to execute a backhand and to execute a forehand and to execute a volley and to execute the serve. And each of those can be trained separately, independently. However, even after training very hard and for very long into all those strokes, we cannot say that athlete has achieved expertise in playing tennis. It has a skill, but to become an expert is going to need a method by which deploy these skills and a framework that will facilitate the brain's integration of all of the above: no information, knowledge, skill. Therefore, the first pitfall that I find, and you will be the ones asking me the questions and showing me whether I understand or not. I remember the process of becoming an expert. And I, I remember that I spent a lot of time in singular skills. For instance, I spent a lot of time just practicing the insertion of one needle, and I wanted to do it painlessly. I wanted to do it with precision and clarity of the target, and that required a very detailed knowledge of anatomy in general. Then peripheral nervous system anatomy, then palpatory anatomy, and then the physical skill of stabilizing the flesh and the skill and with the tube or without the tube. So I practice both with the finger like this on the needle, push that finger technique. And I practice and practice. First, I practice on an orange, then I practice on different materials, and then practice in human flesh, and I practice on the areas that were less sensitive until I was able to do that with no pain, no discomfort for the patient in any area of the body, including intraorbital insertion of a needle, as I've done in different parts of the orbit. You know, there are classical insertion sites, and it could be a useful thing for either an eye problem. I treated postherpetic neuralgia on on the optic nerve. I've treated other eye affections using those needles. I've treated fractures on the face, which are difficult to treat otherwise to decrease the edema. So the single skill of putting a needle, which is equivalent to the skill of cutting vegetables that the aspiring sushi masters have to do for the first year of their training in Japan, one full year devoted exclusively to cutting vegetables until you can do that to perfection. So one advice I have for all of you who want to become eventually experts at the at the problem solving of helping patients with pain with movement disorders is to work on the different skills. Some of you would need better palpation, some of you would need better anatomy knowledge prior to the palpation. So some of the gaps would be on the knowledge, some would be on the skill. And after that, or simultaneously, I like to give you the framework, which I already been talking about, the method by which we can apply, organize all this knowledge, all these skills, and interact with the patient by means of these needles, these acupuncture needles, and the electrical stimulators. And for that, I'm giving you a methodology, but you could not profit from that methodology unless you are able to analyze the pain problems from a neurofunctional perspective. And that's where the method by which I approach the analysis of the pain with movement disorder, I call it neurofunctional operating system. So briefly, and I like to start having questions very soon, just let me give you a brief. I'm going to share my screen. You should be seeing my PowerPoint slide. And this session promised, very big promise, to discuss the what, where, when, how, and why of the neurofunctional electroacupuncture methodology. However, I'm going to simplify and go back to what I started with, which was the fundamental question in clinical practice, which now I'm going to expand to fundamental questions. The fundamental question, if you remember, was to have a target. If we don't have a target, we cannot treat. That's very tautological, but very profound. And in the selection of this target, will lay the majority of the success in the intervention. So the clinical methodology involves, to begin with, an understanding of all aspects relatives to the patient's experience. So here I have to insist on the rigor of taking a proper clinical history. The first skill that we need to develop is interviewing a patient. To interview a patient is like interviewing a normal person, requires the ability to listen, requires a lot of attention to the detail, the words people choose, the demeanor, the circumstances that they refer to, and all that is the foundation of understanding the problem. The foundation is not an image of an X-ray or a MRI or the patient simply referring to a body part. We've already established that that is not even close to enough to be able to advance in that process of selecting the ideal treatment target, because we have talked about a clinical gap that I'm going to find. A clinical gap, that's how I like to illustrate it with the Grand Canyon, because it's big enough for the analogy. The clinical gap is simply the what separates the patient experience, what the brain of the patient puts together, and the physiological reality that involves mostly activities of the peripheral nervous system, the autonomic nervous system, and the vascular system. Obviously, all together with the particular cellular activities, both energy producing and anabolic. And energy producing is catabolic and anabolic processes. So all those things that are happening in the body will convey signals that eventually the nervous system is going to put together. So in terms of knowledge, this is the first layer of reaching an understanding of what could be involved in this clinical gap. So understanding how signals travel and reach the central nervous system, the supraspinal part, is foundational to the method. And if this is your weak spot, get busy filling the gap. Study neurophysiology of pain, study the different types of nerve fibers, study the pathways, the structure of the spinal cord, the segments, the segmentation, and anything that derives from this, the dermatomes, the myotomes, the sclerotomes, because otherwise you will not be able later on to fill this clinical gap. And for those of you still using methods other than neurofunction, please abandon them and embrace neurophysiology and embrace metabolism and embrace science, because I don't think is legitimate to use and substitute this knowledge that we have acquired via the scientific method, and instead using something that is paradigmatic, belief-based, that could have value, but it leaves enormous question marks into the process of achieving an understanding, a true understanding. So, understanding how the nervous system works for real. What is a normal transmission, transduction, transmission, modulation, and processing, perception on the sensory pathways, understanding the phenomena of peripheral sensitization, central sensitization, understanding the differences between neurotransmitters and neuropeptides is absolutely necessary to be successful. And that's one of the reasons why patients with pain get such a mediocre treatment. And that's why we have a tremendous crisis in the pain, in the treatment of pain, and with expenditure on the billions and billions of dollars by every country that render very poor results. And it all stems from a lack of understanding of neurophysiology of pain. So that should be step one, and that's what I did. I got busy. I read the books, I read the articles, and I built my own version of it so I could use it in my clinical practice, and I could use it both to understand what the patient was experiencing and then to understand the effects of my interventions. Because for me, it's not enough that something works. I also want to know why, and therefore I can make it work even better. That's why if I don't understand, all I can do is repeat it and hoping that it's going to work again. But if I have a hypothesis and a mechanism and I apply it, so for instance, I use a lot this universal neuromodulatory mechanism that happens at the spinal cord, that consists of the inhibition of the transmission of nociception by the activity of the non-nociceptive fibers. So this, which is the gate control mechanism, no longer a theory, a well-established mechanism, for instance, led me to develop the painless needling technique, because I understood that if in the process of generating signals, non-noxious signals to abolish the processing of the nociceptive signals, if I incurred in nociception, I was defeating the purpose. Therefore, all techniques based on other beliefs, yin and yang particularly, where you're trying to make something happen based on some ideas that are not verifiable by scientific methodology, definitely you're not going to achieve the same results as if you respectfully, with the nervous system, only generate non-noxious signals, and you do a gentle, painless, elegant stimulation that results in a deeper and more lasting inhibition of the nociception. Obviously, this is still an inferior approach because it's purely symptomatic, but is a skill I use many times a day that allows me to facilitate later on the desensitization of a particular area And that way I can either have the patient moving that body part that before was painful, now is not, or I can use a manual technique and therefore becomes more of a legitimate strategy. Not only I suppress the pain just to make something happen, but without understanding the what is causing it, but I use that as the first step in order to facilitate the following interventions. So this is just an example of how it is necessary to correlate all our interventions to the actual way the nervous system works. Obviously, in the allocated time, we will not be able to cover all, but I will highlight in the methodology the most salient points and important events in order to fill or close this clinical gap. This is based on 41 studies that were published in the British Medical Journal in 2012. And it was focused on misdiagnosis, what we can call cognitive errors. And it was recommended that practitioners should acquire more knowledge and expertise, improve their way of clinical reasoning, which is what I'm advocating, and getting help from colleagues, experts, and tools. Those were the three methods identified. So study, uh, practice reasoning based on actual physiological anatomical knowledge, and seek the expert guidance of those who have walked the path before you. So, as I said, the methodology is based on one actual pitfall. That's the fact that even though there are patterns in the human body, patterns of malfunction, at the end of the day, every person is singular. And at the end of the day, every case is singular. A label diagnosis is not going. First of all, a label diagnosis, in my opinion, is not legitimate. And I say this as loud, as clear as you want to hear it. It's not legitimate because it could be intellectually soothing to reduce pathology to a number of entities as if these entities were real and not fabrications, instead of understanding what is the particular dysfunction of physiology in this specific case and at any given time, because even within the same case, the same person, the pathophysiology may vary. It's not the same uh, to be experiencing a sensitized nervous system under a low barometric pressure system, which will further sensitize the nerves, than to do it in an environment that's dry and warm, for instance. So to best understand the case, we need to deconstruct it to its fundamental components, as well as analyze it in an open architecture manner where there is no definite answer, simply their working hypotheses that we continuously test through our treatments. So the methodology, which I call neurofunctional operating system in general, is it has these key areas. The understanding of the nature of the problem, that is more difficult than it looks like a step. Then what we already have discussed a little bit, which is the understanding of the pain experience events. How is that nervous system? Uh, what is the degree of involvement of certain segments? Is there a visceral component, etc.? Then the other clinical dimensions of the problem, articular, soft tissue, visceral, and combine that with the understanding of the clinical events. And then we can focus on the specifics of the locomotor system, which is complex and has several well-defined dimensions that I like to briefly highlight. But first, back to the pyramid. The pyramid has helped me and helps me every single day tremendously to understand this interconnectivity, this interdependence that exists between the central nervous system, the peripheral nervous system, the digestive system, the cellular activity, and the biomechanics. And nobody can be a full expert on every single layer. That's impossible. But depending on your population, depending on your inclination, in my case, my population is high performance athletes. Yours could be more chronic pain or amateur athletes. In each population, you will find certain trends, certain patterns, again, that are good to guide you to the beginning of this detailed analysis. My only advice is that you look for general training, not in depth. And except on the neurological, I say the neurological should be our highest level of expertise, but the metabolic is hyper complex, and we need other people to work side by side with us to consult the cases. That's what I do. I use a couple of world-class consultants, and if I need them to do a study of the metabolic state of the patient, I send there. We do blood analysis, urine analysis, saliva, stool. We look at microbiome. We look at absorption of different substances. We look at the range of the most important nutrients from essential fatty acids, essential amino acids, vitamin D, iron, which are common deficits. Vitamin B12, a common deficit in the general population, and that already help us big percentage in achieving later on full success in the treatment. It's impossible to treat people without touching the metabolic and getting excellent results. It's just not possible. So whether you do it personally or you refer the patient to do that to someone else, it has to be done. And the biomechanical also, you don't need to be a super expert, but you need to have a working understanding of the mechanics of the joints, the main kinetic chains, and also obviously you need to be good at analyzing people's behavior, detecting wrong thinking patterns, phobias that are preventing movement or changing, the behavior of the patient in a disempowering manner. So the pyramid helps me, and it's just simply a summary of what you can categorize by other groups of categories like articular, connective tissues, visceral, glandular, exocrine, endocrine, peripheral nervous system, spinal phenomena, etc. So that's another way of organizing the clinical information. And here the list of the things that in a practical manner I look in every patient and I recommend you also look, which is here on the bottom, you can see a visual analysis of movement. It doesn't need to be sophisticated. Everybody can see if someone moves a shoulder, that that shoulder is incompletely uh, elevating, for instance, in the picture. You can also see whether that scapula is moving or not. So you have to get used to it. If you are not, no problem. Start looking at people, start looking at movement, and little by little you'll develop the skill. It's nothing extraordinary. It's a simple comparison. You just look at the area where movement takes place and see what's the behavior, the gross behavior. Now, you need to refine that with hands-on, like I'm here on the bottom right of the slide. I'm checking both movement capabilities of that hip. I'm checking simultaneously tensional behavior of the posterior tissues, in this case, the attachment of the hamstrings, because this athlete is obviously is a jumper, a long jumper and triple jumper, so is putting a lot of strain on her hamstrings and adductor magnus and in a lesser uh, in a lesser scale on the adductor longus and minimus. So I'm checking simultaneously because it's not possible to separate the behavior of the joint from the behavior of the soft tissues. That's that's simply a practical recognition of something. Therefore, in my opinion, there's no value in checking the behavior of the movement of the joint in degrees without checking what is really contributing to that restriction, because I can change that restriction in a second, and then what happens with the meaning that you were allocating to a pure quantification. As you can see, most of the methodology needs, and it's not going to change, to be qualitative. And this is something that may be intimidating for many people because we want objectivity. But objectivity will come from the refinement of the qualitative. When you play an instrument, a violin, for instance, you do it in a qualitative manner. You use the sound that comes up to the violin to judge whether you are putting enough pressure or not on the strings, whether the movement of the art is the bow is correct or not. Is qualitative. We do lots of qualitative things. We are engineered to think and behave qualitatively. And the same applies to what the hand feels. When you feel abnormal tissue, could be a little grainy, could be thickened, could be of many kinds. You could feel a crepitation. Well, that's something qualitative, but anybody can feel it. Is no secret. And those are the tissue trophic state, which will help you identify areas of the peripheral nervous system that have been suffering for a long time. So this is the summary of of the steps. You start with looking at the movement. You put your hands on, move the body part, and you can do that sitting, standing, sideways. You should do it in different manners. There is no one standardization because you should examine in the way that the clinical history and the availability of movement permits. So you do your integrated evaluation of movement and tensional behavior, and then you trace or you palpate along the peripheral nerve pathways, and you will identify mechanosensitivity. You can use a special tests like the pinch roll or the or different other tests that exist for the sensory part of the nervous system. I've used all, but the one I use the most is simple palpation, gentle, not very aggressive, to identify areas of trophic changes and allodynia. And then you should devote a specific part of your exam to neuromotor testing in order to identify muscle groups that are no longer firing properly, and also because that is going to be your before and after treatment. And patients will appreciate the objectivity because they are going to feel the changes in no uncertain terms. Then, once you have located in the kinetic chain one or two articular areas and certain peripheral nerves and certain dermatomes, myotomes, then you can refine the mapping of the problem by using all the dimensions of the nervous system that you perfectly know, which are the peripheral nerve pathways, the difference between afferent sensory motor, the segments of the spinal cord, and within the segments, the somatic segments versus the reflexogenic sympathetic segments that will have an impact on the innervation of the vascular territory, therefore becoming fundamental in the restoration of normal metabolic activity. I have to say that most problems can be solved with normalization of the sympathetic nervous system and a normalization of perfusion. That's why gentle aerobic is one of the best strategies for the treatment of pain problems, because per se improves the energy capabilities of the cells and therefore facilitates neuromotor function, and the nociceptors stop complaining as much. All right, so at this point, which obviously is always longer than I anticipated, I'm going to go back to main screen and address some of the questions that may have come.
So if anyone has any questions that they wanted to review or clarify, thinking about how well are you using your own framework for treatment, and what challenges you might be facing that you'd like to solve in a more efficient manner. If you have some ideas about how to implement this kind of framework into your practice.
So my question to the listeners before I get their questions would be, if I was sitting there when you're doing your next patient, how good would you feel about the quality of your interview, about the quality of your examination, about the quality of the insertion of the needles, etc.? So if I was to audit your practice, how good would you feel? Are you aware of the gaps in that cognition that we said the studies identified in most practitioners? Because if you're able to do a good self-analysis, then you can start improving by, for instance, allocating the appropriate time for each segment of the clinical methodology. In my opinion, most practitioners spend too little time seeking understanding, interviewing the patient properly, and quickly they try to fit the presentation into something familiar. Familiarity is a killer. Abhor familiarity. We are explorers. You should be excited every time a patient comes with a problem and forget the labels. If someone says, well, my back hurts, immediately most practitioners are going to close and put there no interest, another back. But the fact is that a back issue can be fascinating because it can have a number of dimensions. It can have a visceral dimension that has been missed by everyone. It can have a kinetic chain dimension that you can fix by working on an old ankle sprain that nobody is addressing and then modifying the force management system and so on and so forth. So this open architecture model, not label diagnosis, not closed diagnosis, is liberating for the practitioner because it makes your work exciting again. So this would be my questions and my challenge to you guys.
You had mentioned about you using a painless needling technique. Can you explain a little bit more about that?
About that painless
You have a painless needling technique.
yeah. Well, the painless needling is very simple because the majority of the discomfort in the needling occurs on the superficial layer. The dermis is the most innervated layer on the cover of the skin. The skin has the dermis, the epidermis, the dermis, the hypodermis. So if you're able to compress the tissue and using a fair amount of force, you're able to pass that layer quickly. Paradoxically, the rest of the insertion is going to be guaranteed that it will not bother the patient. So that requires several things. It requires compression, it requires a firm, which is, these are technical issues. For instance, I do not press the needle with the distal phalanx of the finger. Why? Because if I was to do so, the force generated would not be very big. Instead, I use the middle phalanx, and that simple technical change makes needling 10 times more comfortable for the patient. So here we go back to skill and expertise. Um, it would be better for you to spend 1 or 2 hours with me in the clinical setting than listening to me for 200 hours. I promise you that. The same way it was for me to see different people all over the world when I was acquiring building my skill set. So I think that the message today is multiple, no? The first is, okay, question everything you do. Don't be afraid of questioning. Uh, Results should be the only metric, results, not reference to an orthodoxy, not your professional regulatory body, not your, no, results. Happy patients, patients that go back to function. That's the metric I use. In my case, it's not an easy metric because these are high performance athletes and they have to go back to a level of performance that if you don't do a good job, it's not going to happen any other way. But most patients are equally challenging. I don't say that high performance is more difficult. Maybe you have to be a little more refined, no? But yeah.
Can we stay on this needling topic?
Mhm.
Um, are there sometimes areas that are more densely innervated and cause symptoms on insertion even when done swiftly?
Well,
That's
obviously
like an uncomfortable sensation cutaneously with no
yeah,
bleeding or touching the vein.
it's a lot more challenging to needle the anterior aspect of the body because the anterior aspect of the body is the one that contains more vessels, more nerves. So the back is easy because it doesn't, even the 2-point discrimination, if you do it on the back, is pretty broad. If you do it on the hand, for instance, on the thinner muscles, is very narrow. So we have higher density of innervation on the distal parts, on the face, and on the front, and on the inner aspect of the arms and the legs. So obviously, in those areas, you have to be even finer. Paradoxically, for instance, if we talk about the tool, I use needles that are either 0.25 diameter for the shorter needles and 0.30 for the longer needles. Because if you try to put a 0.25, 70 millimeters, even on the posterior, is too flimsy. It's not going to give you enough control, and it could be more bothersome because the fact that the needle is a little thicker, it doesn't have a bearing on the discomfort. It's more the stretching of nerve fibers that causes the sharpness and the discomfort. Also, you have to understand what are you touching, depending on what people. If it's sharp, it's the fascia. You're probably involving an A delta fiber, and you can quickly pull and push, and then ask the patient, okay, should I take it out? That's what I ask. And I said, oh no, it's going away. So you have to learn how to react in terms of what the patient tells you. Uh, if the patient tells you, oh, still it's a dull ache, then it's not an A delta fiber, it's not the needle in the fascia. It probably you are touching maybe a vein or another structure. So then you take it out and you go back. If it's a paresthesia, then you've touched a peripheral nerve. You should know which nerve is because, okay, you're doing something on the area, let's say kidney 3, classical, so is the tibial nerve. So you've touched the tibial nerve, the patient feels something on the sole of the foot. At that point, you can stop and say, well, it's still there? No, it's going away? Okay, fine. Yeah, it's still there, so it means you're touching the nerve, then you move the needle. So there are lots of technical refinements that come from simply understanding the reaction and what's in the area where you are. So that's what we say. There's a reason why the sushi master has to cut vegetables for a year. And we should practice in every treatment. I practice one needle technique, one insertion, focus, stimulating by hand with no pain. The patient says, is the needle there? It's still there. That's what you want. So to get that mastery of everything, the interaction between the needle and the nervous system of the patient.
So I think that's kind of answered this other question. Do you have any principles you use when needling a very sensitive nervous system?
Yeah, the same a good firefighter follows. So what does a good firefighter do when there's a big fire? It looks for a chair, sits there, enjoys the fire, and waits for the fire to come down. So I don't fight angry nervous system. I've learned my lesson, and you have to operate with a perimeter. So depending on the circumstances, I would interact with the closest available nerve that is willing to bring my message to the central nervous system. But a very sensitized nervous system, you cannot touch it. So if you have someone with painful regional pain syndrome, you cannot do anything because you're going to make it worse. So the what you need to do is get a good feeling based on the history, based on the behavior, based on your examination of the degree of sensitization, and then go to the posterior primary rami to the back and do that first, and then go back to the periphery and see whether that has changed, which it does often. Go proximal, go distal, and yeah, but don't go head on.
What if you're dealing with somebody that's nervous about needling? Is that a different kind
For
of
sure.
setting?
That's almost a contraindication. I don't try to convince people if they're unable to trust you, if they're unable to relax. Like some people don't like to fly, to fly. Well, take the train. I fly everywhere and I love the planes. The safe is fast, but if you have, needle phobia, don't try too hard. I've learned my lessons, as I said, when I was younger. I tried to win all the battles, to fight all the battles. Now I choose my battles, you know, and I think that's wise. So obviously, reduce the number of needles, select first areas that you know they're going to be more comfortable. Use the posterior part of the body, the multisegmental. Prepare the tissue manually before you put the needle, etc. Create the environment that minimizes the anxiety and yeah, play safe.
Do you have any recommendations for good papers or articles or books to help better understand the neurophysiological effect of needle insertions and the effect of electrical stimulation?
There is no one single. There are many, but also may not be efficient use of your time. As I said, if I say, okay, I read 3,000, 4,000 articles easily on acupuncture, electroacupuncture, how much did they help me advance my skill and then my expertise? I say very little, very, very, very little. And therefore, it's good to read, obviously, but I say put your time into the real thing, a human body, a patient. Obviously, study the basic anatomy. For that, there are tons of books, the neurofunctional anatomy. But in terms of the specific, the needles have a number of effects that I have already mentioned to restore perfusion via some sympathetic and local reflexes, to restore integration of signals in the spinal cord, and to do neurohumoral things centrally. And those effects are what they are. The better results are not due to different effects. All the patients profit, all the practitioners profit from the same effects of the needle. Is the selection and execution. Goes back to the analogy of cooking. You can have the same ingredients, everyone. You can go 25 people and give them the same ingredients. I guarantee you that the 25 dishes are going to be very different, from delicious to, not very good. So,
If people can't attend the McMaster program, do you personally have other opportunities for them to learn or work with you or observe?
well, I'm working on it. I'm working on creating a program just online, cases, case base. Of course, you will have access as well to all the recorded material, but the key would be a 2, 3 hour case once a month, 10 a year, and with opportunity for interaction. And I would do the case from beginning to end, because you need to build a database. That's why in ancient times, apprenticeship was the basis of expertise, and it still is nowadays. No good person in anything uh, lacks a mentor. Whether you're a musician, whether you're an athlete, whether you're a financial person, you need mentors. We all need mentors. And I advise that you grab whomever you can find that's good and gives you that opportunity. In few months, I'll have something out there that you would be able to access. It'll be announced appropriately.
Does anyone want to share like their practice or have questions about maybe where they think they want to fill in parts of their practice that they have questions about or need clarity around?
So the other thing is don't try to change everything at once. I understand it's not possible to overnight change. Start with the basics. Say, okay, I'm going to take better histories. And every day, as I did for years, I got home and I would review the history of every case I had. And I would identify the gaps, say, oh, I forgot to ask this. Oh, I should ask that. And then I would contrast that with the inputs that I provided because I would record all the inputs and then the same. I could have added this. I should have maybe not added that. And that's how every day I use what is called deliberate practice, meaning a feedback mechanism that allows you to understand how well you're doing something. So at the end of the day, you should be your own mentor at that level, and you should be spending time. Later on, I stopped doing it because I didn't need anymore. But it's very important that that you become uh, cognizant of your own methodology. And for that, you need to dispel your ego and see yourself as Leonardo da Vinci, as a student, as someone who is always learning. And that's what I do. I try to think every day after I do a case, okay, what have I learned? What have I done? Have I been focused? Have I been sharp? And you have to be exigent with yourself. You have to have a high standard and hold yourself to that standard, even if nobody's watching, because it's very easy to go down. And the other thing is, if you're not improving, you're going down. Make no mistake, there's no steady state in life. That's something important to acknowledge.
We have a couple of very specific technical questions now. Can we address the spasticity caused by upper motor neuron lesion using electroacupuncture?
Okay. Upper motor neuron lesion is a disconnection between the peripheral part of the nervous system and its effectors, which are muscles and glands. Once you have the disconnection, there is a certain neuronal regeneration, very well studied, but per se, the parts of the nervous system that have been disconnected and damaged, I don't think we can force to reconnect. What we can do, and this is a clinical insight here for you, in any clinical condition, whether upper motor neuron or any other, what you see clinically will be 25% worse than it needs to be because we have a system which tries to protect itself. Therefore, there is always some adaptability for the taker, whether you reach that adaptability with needles, with movement, with imagery, is there for you. So I treated many stroke patients and I've seen progress. The progress is obviously bigger on the lower extremity, on the larger motor units, but I think it's accomplished via awakening dormant motor units rather than reconnecting. Now, having said that, if you get the stroke patients at the beginning, then scalp acupuncture has proven to facilitate some of the central regeneration of of the neurons. In Korea, in Seoul, there's a hospital, Eastern Western Hospital at Kyung-hae University, which I visited many, many moons ago. And they have excellent information on that, and they have great success with their patients. Kyung-hae, I think it's Unhe. You check Seoul, Kyung-hae is a private university, it's very famous, and you'll find it. And their Department of Physiology has published some of the best studies on strokes.
Okay, this is a technical question. It's very specific. So, with needling on posterior chain, bladder points along erectors, and a rosy reddish color appears around each insertion site, which dissipates with time. What is this reaction indicative of?
Those reactions are histamine released by macrophages. Macrophages are pervasive in the body. These cells contain, they're part of the so-called granulocytes, and they tend to accumulate on the area of the nerve ending, the nociceptors. And if you have a sensitized nervous system, you could have more of these macrophages. And when you put the needle is a foreign object. It triggers a response, a normal beginning of an inflammatory response that then doesn't result in permanent, but in a transient just vasodilation, which is the reddening that you see. And then once the histamine is reabsorbed, the vessels go back to normal diameter, then the redness disappears. It usually is pretty benign, and although there are few cases described in the literature of people who may have allergic reactions, but this is like just a simple histamine release from the macrophages.
I know that you've got, some discounts for other practitioners, for other acupuncturists, but somebody's asking, how difficult is it for a TCM acupuncturist to adopt the medical acupuncture, specifically biomechanics assessment?
Is not intrinsically difficult. Is like asking how difficult it is to go from the bicycle to the motorbike.
Right.
Um, you learn how a motorbike works. You practice in a parking lot first. You don't go on the road trying to hit 180 kilometers per hour. So I think many professions have gaps, knowledge gaps, and whether massage therapies, whether TCMs, each person should identify the gap, and you can fill it. Obviously, you have a disadvantage, but you also have an advantage. You have the advantage of it's like a psychologist who have read many books, having met characters in the books, classical books, from the Greek tragedies to the Shakespearean. Well, that gives you insight into the human nature, and that's applicable when you're going to have a practice in psychology, even though you're not going to use a pure, analysis to say, oh, you're like that character in that book. But is valuable. So you've learned valuable things, and what you need to do is update the operating system to have a more predictable, objective methodology that is going to help you evolve versus paradigmatic models that are stagnant. They don't allow you to evolve.
It's, it's a great way to think of it. So somebody was saying something that they find tricky is when it comes to selection of the modality of treatment. That's in part why I have a lot of mechanism-based questions. How does it work? How long is it? Not a great question, I know. So considering it seems to take a bit more time, 10 to 12 minutes I've been trying lately. So I always wonder if I'm using my time and my patient's time wisely versus doing something that I'm more used to and can reassess faster, manual therapy, trigger point needling, etc. That being said, I've been finding this material and seeing some practitioners use it very useful.
Well, we'll go back to the kitchen. In every kitchen, you have spices. You can have 50, you can have 75. At the end of the day, the quality of a dish is not in the number of ingredients, it's not in the number of spices. Indeed, I think that minimalism should be, or essentialism, if you wish, should be the goal, meaning try to distill the problem to its key components, go to the first highest value node that you can identify, and then select depending on the not just the target, but the goal. So if your goal is to restore perfusion, then use the technique that will, according to your understanding of that modality, lead there the best. And test before and test after. You need clinically meaningful outcomes. That's mandatory. So clinically meaningful outcome should be of functional nature. So could be a movement, could be a resisted test, could be doing something the following day and then reporting to you. So I say select better your fundamental dysfunction and your fundamental target, and then narrow to the modality to the one that you think that's going to work the best. Then do it, test it, and learn from it, and then continue to grow that. And take your time. Use less tools, but use them in more refined manner.
And I know that maybe you cover this in one of the six parts, but could you briefly discuss the frequencies you use on your instruments when needling and what you use specific frequencies for?
I use one frequency 99% of the time, so it's pretty easy. The lowest that the machine allows, which is 1.2 or 1.1 hertz. Why? Because there's no advantage using 2, 3, 4 hertz, and it would bother the patient 2, 3, 4 times. If you have a gluteal musculature contracting during the treatment, if you do it 400 times or you do it 100 times, well, there's a difference. So I use one because it gives me all the effects. By virtue of location, it gives me the local effect. By virtue of the frequency, it gives me the central effect. By virtue of the signals traveling the spinal cord, gives me the segmental effect. So it gives me everything. I don't try to play with the frequencies and say, oh, now we're going to do a dynorphin A, dynorphin B stimulation, and then I'm going to change and I'm going to do GABA at 80 hertz. There are stimulators that can program by that. They have 1, 15, 20, 80, 1, 20, 150, 250. My opinion is if you cannot do it with one, then the problem is not in the frequency. So I I go back to the basics, the man who uses, just like Bruce Lee said, fear the man who practice one technique 1,000 times, not the man who practice 1,000 techniques one time.
Is it appropriate to use electroacupuncture for the nerve pain caused by metabolic cause like carpal tunnel or infection causes like trigeminal neuralgia? If yes, what should be the approach?
Trigeminal nerve, leave it alone. Don't put electricity nearby. In a situation of sensitization, to put electricity is like putting dynamite. So stay away from it. Now, the percentage of gains that you can have in complex situations, whether there is a metabolic dimension, segmental, vertebral dimension, peripheral dimension, it varies. Again, it's very valuable to restore perfusion and even things that look pretty bad. When you restore perfusion, they usually respond very well. So from that standpoint, the simplest approach to all peripheral neuropathies is to do the paravertebral musculature, to do the C7, T5, and the T10, L2 segments because they are the most reflexogenic, vascular reflexogenic, and they facilitate the restoration of perfusion via normalizing vasomotor control. And I've had patients who had scheduled surgeries for carpal tunnel that cancel the surgeries because the symptoms disappear, not even treating peripherally, just treating axially. I find a lot of value in that.
Excellent. Um, what do you think is the mechanism? Sorry, what do you think the mechanism scalp acupuncture for improving neural output or modulating the body?
The mechanisms are studied by these people in rats and other animals, and have to do with the reflex. Again, you're not touching the brain, obviously. So scalp acupuncture, it could have two mechanisms. One, reflexogenic, which involves secretion of certain proteins that are favorable for the metabolism of the neuron. And there are many articles that you could find from these people from Kyung Hee University. And then most likely there is a electromagnetic mechanism by the body has self-regulating abilities. And when you do something that challenges one body part, but without overwhelming the self-regulatory mechanism, then it usually ends up producing a positive sort of regulation or resetting. So if you put needles, which I've done many times, over a motor area that has been affected, then likely is going to be some sort of electrical activity there that is going to tend to improve things. Why the direction is in improvement, I think because of the existing self-regulatory circuits that many of which we don't know well.
Um, when doing skin rolling, is there a way to differentiate between trophic changes and just increased subcutaneous tissue?
Well, that usually is what it is. Many people, obviously, they're fat cells, they're adipocytes many times in areas that are trophically changed, such as in the lower back. You see patients that no longer is possible to take a fold, a skin fold. It's impossible. It's so thick, it's so stack to the subcutaneous. So, I mean, those are like gross, major, giant trophic changes. Then there are the smaller ones that you can really feel is becoming grainy, and it's not yet too big. The thickness you can feel that on the peripheral nervous system. Well, areas like the deltoid, for instance, the thick ones are common here. In other areas near the elbow, you can find them thinner. It's a lot of fun. Just palpate the peripheral nervous system, and you will discover these things. And you will discover also that after a little massage or my own technique, the micro conditioning, that the tissue becomes smoother, part of it could be vascular reflexes with better perfusion. Part of it, I don't know exactly what we're doing, but the fact is that you can change that. So trophic changes again is a broad terminology, and it varies by body part and by percentage of fat of the individual.
I know that you had mentioned about histamine response, but this is another specific question. So, after needling in the temporalis area, a reddish bump appearing about 48 hours later, no bruising, stayed for about 2 months. Nothing really on ultrasound, seemed to go away with pressure only. Do you have any thoughts about that?
I would have to say, but to see it. But if it didn't show, so it's easy to, at least by palpation or by ultrasound, to identify the depth of where is that happening. So even if we don't know what it is, but where is this? Is this in the subcutaneous, or is this deeper to the fascia, to the superficial fascia? So that's a critical difference, because to me anything that is superficial to the superficial fascia is of lesser concern. What it is could be a little vein, could be, something of that sort. A little vein, even if there's no bruising, that probably was a little vein, which it doesn't show in anything, and it could be there protruding. Those things typically are self-solving, and then they never become really a problem.
Can you describe what trophic changes in the spinal muscles around the spinal root area are? What does a trophic tissue change feel and look like in this area?
Is like a bad fabric versus a fine fabric. So you have a fine fabric, it feels smooth, uniform texture, and the trophic changes simply is that it's thickened. It's like if you're wearing something that's not refined, one of these jackets that the old military they used to make,
The
or those
canvas.
towels in the hotels that are exfoliating instead of drying you. Well, the same thing is a qualitative first of all, and then is the thickness and the resistance to movement. So when you do the pinch roll and you roll it, and you see that it gets stuck because it has adherent adhesions to the underlying tissue. Just palpate the few bags and you'll see quickly examples of this.
How effective is auricular acupuncture for autonomic dysfunction treatment? Usually, how many sessions or how frequently are necessary to see a good outcome?
Is very effective. We know that because there is a lot of research on it from England, the UK, and from the United States. So the ear being the only part of the body that's innervated by the vagus nerve, the concha is vagus nerve. Also, the trigeminal nerve innervates the upper part, the triangular fossa, and the part of the helix and the root of the antihelix, and also has cervical plexus innervation. So it's a window to the central nervous system. Simply messages sent here will reach a lot more part of the nervous system, and it has a very powerful sympathetic modulatory effect. You can see that when, if you want to soothe a baby, you just gently massage the auricle, and the baby will calm down. Even an adult, you can try that. And it is, again, it's a window to the central nervous system, and it has a very powerful modulatory effect. How long will it last? Depends on the dysregulation. I use auricular to treat heroin addict, and it was very effective, but it didn't last beyond few hours. But repeated treatments have proven to be the most effective intervention for heroin addicts in other difficult cases, even in prisons and other institutions. And there are studies on the hundreds of patients published, as I said, in the UK, as well as in the US from the Lyndhurst Hospital in New York that started the detoxification, the addiction protocol.
Um, so somebody recalls that electroacupuncture is contraindicated in patients with a pacemaker. However, do you think
It
it
is
is still
not.
okay? So it's still safe as
It
long
is
as you
not.
don't traverse the heart or the pacemaker?
Yeah. So the only true contraindication of acupuncture is someone who doesn't want to be needle. Uh,
Electroacupuncture.
Electroacupuncture. Other than that, there are no true contraindications. Now, based on precaution, obviously, a pacemaker is designed to withstand electromagnetic fields and electric disturbances because otherwise the person could not live in a world where we are surrounded by electricity. So in the literature, there's only one case, one case over hundreds of millions of treatments in which there was a disturbance, which we don't know the specifics. And okay, as a precaution, do not put the electricity over the pacemaker or in the proximity, but you can perfectly do distal points with electricity in a patient with a pacemaker. I would have no problem. I've done it, and I've never heard anybody having any problem because there is no the design is such that with the type of electricity that we use with the stimulators, it is impossible to cause any disturbance.
What will your targeted acupuncture points be if a patient comes with uncontrolled high blood pressure? What would be your advice?
I would not try acupuncture for uncontrolled high blood pressure. That's foolish. That person needs powerful medication and quickly because that situation you can only regulate blood pressure with the needles within very small margins. So essential hypertension requires medical treatment. Period.
Theoretically, how long after the actual needling treatment is the body auto-correcting?
That's a very good question. And because there are numerous different mechanisms involved, I say it regulates from the moment you start till 72 hours later. So different, the immediate local vasodilation takes place within 10 minutes, but other effects such as the neurohumoral require 24, 48 hours. The cholinergic activation and the anti-inflammatory, that takes something between 2, 3 days. So there are different parts of the system that are stimulated and will act accordingly over the following days.
Would you initiate treatment differently with patients with poor metabolic function? Would you approach neurofunctional acupuncture and local reconditioning treatment in an altered way?
Absolutely. You can only extract what is there. We don't put anything on the body. We just facilitate the expression of this self-regulatory and obviously a patient with low metabolic capabilities the what you can do is very little. So I would narrow quite a bit my expectations and my the length of the treatment, the number is equivalent. When you have these questions, think about the gym. What would you do with a person who hasn't worked out, who's fragile if he goes to the gym? Well, I would give the person very basic exercises for very short. Uh, our treatments are very similar to a gym session. So think about that, and then it's much easier to decide how to select time, intensity, amount of needles, etc.
What can cause a drop of blood pressure during electroacupuncture, and how often have you experienced this?
That's a very basic vasovagal reaction that could be triggered by heat, by smell, by pressure on the eye, by a needle in which in any area, but maybe the shoulder, particularly the base of the neck. So vasovagal reaction, which involves a drop in blood pressure and which should be treated by letting the patient lie down, elevate the legs, facilitate the venous return, and stimulate manually here, the GB26, and that should be enough. It's been many years, frankly, since I saw one, but I had my share of those at the beginning. I don't know why now I don't have it, but maybe my patients are tougher. But yeah, I had few. We all had some. It's gonna happen. So just be ready and act accordingly. As I said, apply protocol, remove the needles, lie down, elevate the legs, stimulate here, and call the day for the treatment.
Any suggestions for neck cervical dystopia?
Not sure that what is cervical dystopia, so I would need to know exactly what that means.
We'll let them clarify. It's great with the different questions, and you come back to a very similar theme around the thinking, but the questions really kind of highlight those themes. Sorry,
Well, I think it's
dystonia. Dystonia. Sorry.
oh, dystonia. So. Well, dystonia could be spastic torticollis, I understand, or problems with the neuromuscular junction. This is the universal answer for all the questions, can you use electroacupuncture to treat lateral sclerosis, amyotrophic, this and that? Okay. You can use acupuncture on people who are suffering of anything, but you cannot use it specifically to treat those conditions. So I think that's very important distinction. So what is the goal when you use acupuncture on a cancer patient? Your goal is not to reverse the cancer. Unfortunately, that's not in the power of the needle, but it's legit to help regulate the system that's under duress and is beneficial even for the specific condition that the person is having. In other words, we don't treat the conditions, we treat the system, we support the system, we support the person. So if you think like that, it would be, again, much easier to design a treatment that makes sense for that patient, clarifying what is your goal. So I put needles on the ear distally, simply to regulate sympathetic and provide some anti-inflammatory effects. Regardless of what was the condition. Maybe a person who had surgery for cancer on the neck. I'm thinking cases that I had in the past. Could be a person who had heart surgery. I'm not treating those conditions. I'm treating the patient. I'm supporting the patient. The needles are fantastic to elicit regulatory responses that are beneficial. I just put it in those terms, and then it's much clearer.
Thank you so much. I know that we have taken more of your time tonight. I'm glad that people got their questions in. I hope that everyone has a clear understanding or a review of some of the parts that Dr. Elorriaga has shared with us. If you wanted some practice knowledge questions, you can always reach out to the email that I put in the chat. Is there anything else, Dr. Elorriaga, that you wanted to end with?
Nothing specific other than the encouragement to focus on progress, not perfection, and a little bit of progress every day lead to a lot of progress over time. And that's the way I've done it, and that's the way all the people I know that are excellent at anything have done it. So everyone should be not intimidated by the magnitude of the task, because we're talking about the most complex job in the world, which is to deal with the human body. And we are always learning.
So I know that we have promised a live case presentation
We
for the
will.
next part. We are hopeful that in a week we will either have a date for soon or after the World Cup.
All right. Yeah, that's unfortunately that's the nature of this working environment where I have to operate. So you will know in few days one way or the other.
Thank you so much for your time, Dr. Elorriaga. I know that it's quite late over there. Thank you, everyone, for joining us and bringing your questions. And
You're
we'll
very
be in touch
welcome.
soon.
Have a great
Thank
day.
you.
Ciao, ciao.